Thanks very much. So my name, as I said, is Townsend. I'm an infectious disease physician currently working in St James's Hospital in Dublin, and I'm also undertaking a PhD in the area of HIV and ageing through Trinity College in Dublin as well. Firstly, I'd like to thank you for allowing me to present this case, but I have a confession. It's actually two cases, but they're a married couple, so it felt wrong to split them up just for the purposes of a presentation. So, I got the wrong one. I'll introduce you to them. So, HIV first really became apparent in Dublin in the 80s, and it came along with an epidemic of heroin that mainly affected urban centres, specifically lower socioeconomic class, and particularly those living in high-density social housing, which is seen still in Dublin today. So they were married and they shared everything, and unfortunately that included needles, so both were diagnosed with HIV in 1985. And as was typical of HIV in the 80s, they were diagnosed late. So the husband presented with cerebral toxoplasmosis, and his wife presented in the same year with fungal tricuspid valve endocarditis. They did incredibly well with early treatment, both of their opportunistic infection and their virus itself. But as you can see, they've had a somewhat rocky course. As well as HIV, they were also co-infected with another bloodborne virus, hepatitis C. The wife, in this case, managed to clear it herself, but not before she became cirrhotic. Her husband also became cirrhotic and failed interferon and required DAAs to cure his hep C. He also suffered a spontaneous subdural hemorrhage and subsequent epilepsy. He has osteoporosis with a severe collis fracture of his wrist that still hasn't been aligned properly and has left him with severe disability. And he had a little bit of chest pain. It turns out he has marked stenosis of his LAD, so has had multiple stents put in. His wife has had a similarly rocky journey. Her ensuing valvulopathies following her endocarditis has meant she needed a pacemaker inserted. She has severe COPD, and she's recently started long-term oxygen therapy. And based on her MOCA cognitive assessments, she has mild cognitive impairment. So they've had a rough run despite doing very well. So where are we today? These are a couple aged 55 and 53. I've outlined already that they have multimorbidity. They have what goes hand in hand with multimorbidity, which is polypharmacy. So they're on double digits of tablets every day. And when you ask them what tablets they take, it's not the names, it's the blue one, the pink one, 2 whites in the evening. They're functionally impaired. As I've already said, the wife is oxygen dependent, she has mild cognitive impairment, and her husband, through a combination of osteoporosis and osteoarthritis, mobilises with a walking stick. And I think, most importantly, they're socially excluded and have been all their lives. They've grown up in deprived circumstances. At the moment, they're living in a one-bedroom flat or apartment. Also in that one-bedroom flat and apartment is their son and their grandson. They've been off drugs for many years now. But I think it's clear that they're frail by any subjective measure, but are also frail objectively. Their Freed frailty score is 4 in both cases, which marks them out as frail. And on the Rockwood score, they would score mild to moderate in frailty. And I think this is leading us to a paradigm shift as HIV physicians. It's well established, and this is some really nice data from Schoten et al. It was published in CID in 2014, that shows people with HIV suffer non-AIDS associated multimorbidity at a much earlier age than their HIV negative matched. And that's been echoed throughout today. But most concerning is that they're suffering these multimorbidities in ages that wouldn't traditionally be considered geriatric populations. So I think the paradigm shift that we need to do is shift away from a chronological view of age, where you look at someone's date of birth and treat them based on that, and look at a functional or biological calculation of age. Because at the moment, this patient is falling down that socially excluded gap because there are no services to provide functional support for independent living for people until they reach the geriatric cohort age, which tends to be over 65. There is, of course, the ability for them to go into a nursing home, but I think from all they've come through to tell them, I'm sorry, we can't help you live alone anymore, you need to go into a nursing home at 55, I think that's a failure of our system. So I think as HIV physicians and researchers, we are going to see a growing population of people who have multimorbidity, are frail, but aren't traditionally viewed as geriatric, and we are in an ideal position to advocate and give them a voice, given that they are so often marginalised. And I think that case hopefully illustrates that point. So all that remains for me now is to thank you very much for your attention. Thank you.